My name is Carlos Chaguay. My topic is maintenance allophobic for germline BRCA mutate metastatic pancreatic cancer. Definition: although systematic therapy for metastatic pancreatic cancer has improved overall survival is still less than 1 year, and no target or immunotherapy agent be approved to date. This disease investigator now report results of the international double-blind randomized control based triple trial evaluating the polyadenosis disulfide ribose polymerase PAR inhibitor allophobic in patients with BRCA germline mutates and metastatic pancreatic cancer.
My lab here in the Gurdon Institute is focusing on how cells respond to and repair DNA damage within the cells of our body. We're interested in this from an academic perspective, but for many years we've also been very interested in the idea that out of this new knowledge that we're generating, there could be therapeutic opportunities for new drugs, for example, for cancer, but also for other diseases. So the developments that we're talking about today relate to a brand new anti-cancer drug called Lynparza, also known as olaparib. And what this new drug does is work against serious ovarian cancer through a mechanism that has not been exploited before in the clinic. The basis of this new drug is to target DNA repair pathways within human cells. So it turns out that every cell in our body is sustaining DNA damage, and that damage needs to be recognized and it needs to be repaired. Because if the damage isn't repaired, the cells of our body die. The DNA is the genetic blueprint which needs to be kept intact. Now, the way that works within our cells is that every cell is sustaining DNA damage, but there are certain proteins in the cell, molecular policemen, if you like, whose job is to carry out surveillance, looking for DNA damage, and when it occurs, to recognize the damage and then repair it. PARP stands for poly-ADP ribose polymerase. So that's a rather complicated name, but in reality, what PARP does is fairly simple. It is a molecular policeman. It's a protein that carries out surveillance activities within the cell, not normally doing very much, but when DNA damage occurs, PARP binds to and recognizes the DNA damage, and then, like any good policeman, I guess, sets off the emergency services. And those emergency services are the DNA repair pathways that PARP recruits to sites of DNA damage to mediate the repair. What this drug does is take advantage of a vulnerability, a weakness in cancer cells that isn't present in normal cells. And very simply, what this means is that normal cells in these patients have two ways of repairing DNA damage. The PARP inhibitor, by binding a protein called PARP, inhibits one of those pathways, but the normal cell still has the other pathway, so they can survive. The cancer cells in these patients, however, lack this backup pathway, so they only have the PARP pathway. And so the cancer cells, when they're treated with the PARP inhibitor, this takes away their only way of repairing DNA damage. And that's how the drug kills the cancer cells, but not the normal cells of the patient. So this news represents a wonderful step forward for certain ovarian cancer patients with these hereditary mutations in BRCA1 or BRCA2. But clinicians and researchers such as myself are also very, very excited by the fact that other opportunities seem to exist. This backup DNA repair pathway is also defective in other cancers such as breast cancer and also others. So hopefully over the next year or few years, hopefully we'll be seeing the development of PARP inhibitors against a wider set of cancers.
Olaparib is a PARP inhibitor. The enzyme PARP is very important for repairing single-strand DNA breaks. And if we inhibit PARP, it means that those single-strand breaks can't be repaired efficiently. And then as the cell goes through cell division, they get turned into double-strand breaks, which are actually quite lethal to cells. So after a while, you get cumulative DNA damage and the cell dies. Now, normal cells have actually got a very good pathway to repair those double-strand breaks, and it's called homologous recombination. But some types of tumour cells have got a deficiency in this homologous recombination pathway, and the best example of that is the BRCA1 and 2 deficiencies. So that's why we get a selective effect on tumour cells with homologous recombination deficiency or BRCA deficiency compared to normal cells.
Application in nursing. In the randomized double-blind placebo-controlled phase 3 trial research evaluating the efficacy of olaparib and maintenance therapy in 154 patients paid and terminally BRCA1 or BRCA2 mutate and the metastatic pancreatic cancer, which had not progressed during first-line platinum-based chemotherapy.
So the POLO trial is the first phase 3 trial to demonstrate that a targeted treatment in a biomarker-selected population of pancreatic cancer patients can improve progression-free survival. This was a global study that looked at patients with germline BRCA mutations, and the patients received at least 4 months of platinum-based chemotherapy with no limit to the duration of therapy. They were randomized to receive either olaparib or placebo. And what we saw was that those patients who received olaparib had a median progression-free survival of 7.4 months compared with 3.8 months for those who received placebo. This was a 47% decrease in the risk of progression or death. Hazard ratio was 0.53. What we saw was that from 6 months onwards, more than twice the percentage of patients on olaparib were progression-free. And what was truly remarkable was that 23% of patients, 23.1% of patients had a response to olaparib, and the median duration of response to olaparib in these patients who had metastatic pancreatic cancer was more than 2 years. Truly remarkable in a disease with such a dismal prognosis. I think the standard of care will soon change so that all patients should be offered the option of germline testing for BRCA mutations because they now have a targeted treatment that can help them. What was really nice with olaparib was that quality of life was maintained over time. And so, remember, patients receiving chemotherapy, it can be quite toxic. Fulfirinox causes nausea, diarrhea, neuropathy, fatigue. And so maintenance treatments enable patients to maintain quality of life while receiving a pill instead of IV chemo. I do think it affects quality of life in a very good way.
And for the future work of this research, maybe would it be possible to look for somatic mutations instead of germline?
Sure, this is a first step. We have identified that olaparib offers significant benefit to patients with germline mutations, and ongoing in future studies, we'll be looking at the concept of BRCA-ness, looking at patients with somatic mutations to see whether we could extend these results to other patients. What's next for this research is to look at this in patients with somatic mutations, to look at this in patients with earlier stages of disease, and to be able to offer this to our patients.
Pros and cons. Pros. The primary analysis of the trial showed T-pains, woe and terminally BRCA mutate and metastatic pancreatic cancer that has not progressed during first-line plain-based chemotherapy and significantly lower progress-free survival with maintenance allopregnanolone than with placebo. The adverse effect profile of maintenance allopregnanolone was similar to that observed in other tumor types. Pros and cons. Cons. Or they do not include patients with disease that progress during the first 4 months of plant-based treatment or who might have continued to receive chemotherapy for the extended period.
So the rationale of the POLA trial was, can we develop therapies that can maintain people who have been on chemotherapy, who have been good chemotherapy responders, but in a way give them a reprieve from big-time multi-agent chemotherapy, as a way of extending their lives, but actually extending their lives in a way that has better quality than someone's life has when they're getting multi-agent chemotherapy. And the group that was chosen to look at in this study was a special small group of people with pancreas cancer. So this group of people with germline BRCA1 and 2 mutations. So we've known from research over the last 10, 15 years that germline BRCA mutations are the most common germline mutations in people with pancreas cancer. Now, many of those people will have strong family histories of breast and ovary cancer, which are kind of the classic tumors of BRCA mutation carriers, but many of them didn't on the POLA trial, and I think that's one big sort of take-home point, and I'll get to that later on, but is that you can't just expect to test people who had strong family history to find people eligible for this drug. There are people on this study who had pancreas cancer with BRCA mutations who had no family history of breast and ovarian cancer, and we've seen that from other studies in the past. So anyway, so the rationale here was identify this group of people, use this novel type of agent, a PARP inhibitor, in this group of people, and see if you can give patients, again, who have responded to frontline therapy, reprieve away from multi-agent chemotherapy with just simply a single agent. I think there were a lot of people who wondered if this would ever work. I think even me, even though I signed up to be an investigator and on the steering committee of this study, I just didn't really know if I thought an oral agent, even a targeted oral agent, would be enough to slow a pancreas cancer down. I think of pancreas cancers as like a speeding train, and even in people under the age of 50 who get this disease, it's a pretty aggressive and awful disease, and most people die within 6 months to a year of diagnosis. So the first goal or the first step of this study was people who underwent germline testing for BRCA mutations. So over 3,000 people worldwide were screened, so it was a huge screening effort to undergo BRCA testing. The people who were positive then had to be on a platinum-based frontline chemotherapy regimen. Most were on some modified form of FOLFIRINOX, which is sort of one of the frontline standards in pancreas cancer. And you had to be a responder for at least 6 weeks, but there was the PI had the freedom to keep patients on that frontline therapy as long as they wanted. So if someone was sort of responding really well, they could leave them on it longer. But anyway, once the decision was made that they wanted to randomize and go over to the PARP therapy, the main thing was you had to continue to be a responder. If you showed progression through platinum-based therapy, then you lost eligibility. So then responders were randomized. This was a 3-to-2 randomization. We commonly got the question of why 3-to-2? That's a weird randomization. And of course, if you think about it, it goes back to the idea that if you're someone who has a deadly disease and you're actually responding to a therapy, it's really hard to think about going off that therapy onto what would potentially be a placebo arm. So to make the odds of being on drug a little higher, it was a 3-to-2 randomization to olaparib versus the placebo.
And so again, after they've responded for a certain amount of time, they can get put on the drug versus the placebo arm. And the primary endpoint of this study was progression-free survival. And as the press release and what will be shown today at the plenary has demonstrated, is that the progression-free survival was significantly extended. It really even beat expectations in this group of people. And so the hazard ratio was 0.53, and the p-value was I believe 0.003. So really impressive numbers in a disease, again, that I think many people wondered if this trial would even work in the first place. So that was exciting. We will have overall survival data. It's a secondary outcome. It's going to take a while because we've actually seen that the people who respond actually have pretty remarkable durability of that response. So the median duration of response right now is over 24 months. So that's like almost unheard of in pancreas cancer, to have even with multi-agent chemotherapy, to have durability of response that's that long is pretty incredible. So to do the overall survival analysis, we're going to need 106 deaths on the trial. So it may take some time before those data come out. We've done some subgroup analyses looking at different subgroups and how they've responded in terms of the progression-free survival. I think the two takeaways from that is basically the response, the progression-free survival was pretty much equal across all groups, including BRCA1 versus BRCA2. They both groups responded pretty similarly. Also, the other thing that was important was people who came in to being randomized who either had CRs or PRs versus people who just had stable disease. And what we saw is that both of those groups had great responses. So that's a huge thing, because I think a lot of people thought, well, maybe it's just the super responders that are the ones that do well. And I think these data show that even with stability on chemo, you're going to do well with olaparib. There was also some health-related quality of life data collected, and I think the punchline from that is that there was no significant decrement to your quality of life being on olaparib versus being on placebo. So I think that's a huge point for docs to remember. Is not only is this a great maintenance therapy for this select group of people, but it's not going to make them super sick, because the difference in quality of life was not very different from placebo. So that's huge. So where are we going to go, or where's the science going to go with this trial? Certainly, we're going to await the overall survival data. There's going to be some other sort of sub-studies coming off of this. I think the next place the science is certainly going to go is there are other groups that have mutations in pancreas cancer that we know about. They probably function similarly to BRCA mutation carriers, so people who have PALB2, CHEK2, ATM. So certainly there will be more work going on seeing if olaparib works similarly in that group of people. They're all part of this Fanconi anemia group of mutations. My gut feeling as a clinical geneticist is it's going to work the same way, because they have similar types of tumors. There's also a group of people who just have tumors that are very responsive to platinum therapies where we don't find any mutations. Are those people also going to respond to olaparib? And I think that those kinds of studies are going to be ongoing as well. I forgot to mention there's also people who have only mutations in like the BRCA mutation group, only in the tumor. We know there's a group of people like that. And so there's already some preliminary data out there that those people will respond to PARP inhibitors as well.
Inces amplified in Ecuador. The Associate for the Fight Against Cancer, SOLCA, report in Ecuador found the National Tumor Registry that the average annual incidence rate of pancreatic cancer per 100 inhabited residents in the Quito between the years 2006-2010 was 94 in mean and 100 for one woman. 4 factors source of the occupation, family and personal medical history, age, gender, etc. were associated with the survival of patients treated of the oncology hospital Solon Espinosa Ayala.
Discuss the results of a randomized phase 3 trial exploring maintenance therapy with the PARP inhibitor drug called olaparib among people with pancreatic cancer who had an inherited BRCA gene mutation. You may not realize that a small percentage of patients with pancreatic cancer do carry the BRCA gene, and that turns out to be an important feature of this study. So please welcome Dr. Hetty Kindler, who's professor of medicine at the University of Chicago, to present the study.
Conclusion. In conclusion, the Polo trial examined whether olaparib could lead disease progression after treating with or more of the initial platinum-based chemotherapy. The use of oral non-chemotherapy medicines with low toxicity source and olaparib will prove an important option, a condition though studying other. Thanks.